assistant of WM, and moderate is Dr. Hari Menon. I would like to introduce Hari Menon in a nice way because he is my colleague and we work together in the Tata Memorial Hospital. And he joined, we were together in one unit as well as the one room. And he is close friend to me. And he is a really one of the best teachers in the country. And especially in the expert in the medical implant malignancies, because in Tata Memorial Hospital as a professor in medical oncology, he was looking after the medical implant malignancies. And whenever we have a problem, we always ask to the Hari, call Hari, and the problem is solved. He is really a dedicated teacher, dedicated doctor, and a lovely colleague. So, and after that, after Tata Memorial, he has joined Bangalore in the St. John's Medical College and working in the consultant in scientific care cancer of Bangalore. And his myeloma, we are having three of the topmost myeloma experts of the country who really, they are wonderful teachers across the country. And Hari is one of them. And second is Dr. Pankaj Malhotra. He is always in all meetings he is teaching us, and he is professor and head of clinical hematology and medical oncology at PGI Chandigarh, and he is the founder member of Indian Myeloma Group, and he is also a member of the board of directors of the International Myeloma Group. He has made the guidelines for the ICMR in different cancers and as well as in the IHBT also. So he is also a leading professor in this field, and today with us we are happy to see and learn from them. And then Dr. Govind Patel, he is the alumni of this college and DM Medical Oncology from DM Hematology from AIMS Delhi, and now he is assistant professor in hematology from Medical College Jodhpur. And Dr. Sanjeev is also associate professor in GPGI Lucknow. And then Kunal Jain, he is medical oncologist at Jeet Medical College, assistant professor in medical oncology in Jeet Medical College. I welcome Hari for moderation.
Thank you, Bhatti sir, for that kind introduction. After a long time, after almost 24 years, I promised coming to Jodhpur. It has taken me 24 years after we were together to finally come to Jodhpur. Thank you for your kind words, and always a pleasure to be with you. He was like my big brother at Tata Memorial, and we used to share the same room during the residency days. And what I appreciate about Dr. Bhatti was that even though he was a senior colleague, he never, even for a minute, shied away from all the duties that the resident had to do at that time, which is admirable. So I just want to see where my other Sanjeev is there. I can see Sanjeev. Kunal, can you just raise your Kunal Jain?
Sir, we have to.
Yeah. Okay. Please come. So, what is it? So, what I am trying to put together is an informal discussion just to stimulate and have a platform for discussing, and I just tweaked it a little bit, just like sifting through the myriad manifestations of Waldenström. Because when we talk about Waldenström, we generally come across any symptoms that we generally see in general medicine. I mean, it's like any symptoms that develop in general medicine, but it has greater connotations if we equate it with Waldenström, because there are so many things that we need to do in terms of deciding whether we need to treat that particular patient Waldenström or not. And Uday had elegantly showed in many of them, there are a good measure of patients who we can keep under observation also in Waldenström. So it's important for us to understand the symptoms and try to delineate what the symptoms are due to, and if it is due to water shortage, those symptoms warrant the therapy. Because at the end of the day, you want to relieve the symptoms of the patient, because we know that Waldenstrom is now categorized as a low-grade lymphoma, and as is true for any low-grade lymphomas, we are looking at trying to control the disease rather than actually eradicate the disease. But the manifestations are quite varied over here. So I just take the liberty of having some case presentation to trigger discussion. So here, as a case study one, I have said a 60-year-old female who was hypertensive for 2 years and dyslipidemic also for the past 2 years, not on any medications. She was vaguely having a history of being treated for some low-grade lymphoma. I could not have any details of that. And she presented in November 2023 with weight loss, anorexia, fatigue, and also was identified to have anemia of a hemoglobin of 8 gram%, mild leukocytosis, 23,700, with predominant lymphocytosis. And what was seen in the peripheral smear, which the pathologist, very important for the pathologist to remark on that, was an excessive ruler formation, which actually raises a red flag over there. And hemoglobin had plummeted while being evaluated to 4.5, and she received 2 units of Paxil transfusion, and thereafter was subjected to a bone marrow evaluation at another center, and then she came with a report of a hypercellular marrow, and the viral markers were negative, and ultrasound was done outside. It was showing a splenomegaly, but you didn't need to have an ultrasound because clinically she had a splenic enlargement of almost 8 centimeters in the long axis below the costal margin. And a provisional diagnosis was probably of a chronic lymphatic leukemia or some sort of a CLPD. And so I just stop over here, and I would just ask, how much of, with this background, I'll start with Dr. Sanjeev. With this background, how will you interpret the anemia over here, given that the patient has manifested with some degree of anemia, plummeted suddenly, splenomegaly in this situation, with the peripheral smear showing some degree of...
This patient is showing roller formation in the peripheral smear, definitely evaluate for either autoimmune hemolytic anemia by DCT-ICT or paraproteinemia evaluation by doing the serum electrophoresis and quantifying the protein and which type of protein by immunofixation. So that minimum we have to do to identify the cause of anemia, other than evaluation of any associated nutritional deficiency by doing ferritin and serum vitamin B12 levels.
In this patient suspected to have the CLPD, and CLPD, anemia in the CLPD may be due to the autoimmune hemolytic anemia. That patient suggests a sudden drop of the hemoglobin within couple of the months. And other than the autoimmune hemolytic anemia, nutritional anemia is also common in these chronically ill patients, like the iron deficiency anemia. And it's a case of the Waldenstrom's microglobin comes to after the investigation. Then one of the cause of anemia in that is hepcidin related anemia that occurred due to the underutilization of the iron and the liquid absorption of the iron from the gut. That causes the relative iron deficiency anemia in this patient. And other related anemia may be there.
So, what about the, how much do you see for the ruler formation? When patients come to us, most of them are having some sort of a hematological problem, some hematological malignancy. How much emphasis do you give to see the ruler formation over there? So will it trigger for us to think of something?
Yes, obviously, if there are some red flags, as you said already, so these are the red flags, which means that you need to investigate these patients. These are not simple anemia. There has to be some reason for this anemia, and already, my colleagues have mentioned about the causes of anemia. The other reason sometimes in chronic lymphoproliferative disorder, this pure red cell aplasia, although it is more of slow growing rather than sudden drop in hemoglobin. And the other thing is, if you are thinking of autoimmune hemolytic anemia, it's a kind of a general rule for the practitioners. Please don't transfuse the patient just like that. Somebody who is already having an autoimmune hemolytic anemia, and if you transfuse, so instead of the hemoglobin going up, it can go down. So this is the only one indication where we tell the resident to take the consent of the patient when you are transfusing blood to a patient with autoimmune hemolytic anemia. So if it is a autoimmune hemolytic anemia, please see what type by doing a stool test and looking at whether it is cold agglutinin or whether it is a IgG, and then giving, if you want to give blood, give very, very carefully and with the consent of the patient. Rest of the, I think the causes have already been mentioned. We are making a diagnosis of CLPD. This is based on absolute lymphocyte count, which is more than 5,000. So even without immunophenotyping, if the absolute lymphocyte count is more than 5,000, you can say that this is likely to be a chronic lymphoproliferative disorder. And obviously these days we need immunophenotyping and many other tests to clearly put the patient into a defined category of a CLPD.
Yeah, so we wouldn't find fault with the fact that given this we were thought of a CLPD, some degree of hemolysis happening, massive splenomegaly, a little bit of lymphadenopathy and lymphocytosis and anemia. So that's what we also went through with this. And so I just come back to, again, I'll ask, is anemia a most common manifestation of Waldenstrom in your opinion?
Usually, most of the patients are asymptomatic. Some may have anemia as a presentation because in the most of the Waldenstrom patient, bone marrow is definitely involved. There is a high degree of bone marrow involvement in low-grade lymphoma, and this patient present to us only when they have any kind of cytopenia in the form of anemia or low platelet count. So, obviously, anemia is the most common presentation for
Would
this
you have
patient.
remotely thought that it could be because of a plasma cell dyscrasia over here? Yes or no? Yeah.
Yes, there is a ruler formation. Definitely, it may be a presentation of myeloma also.
It's just an indication that there is some hyperglobulinemia present, whichever it is. Would that be a current interpretation of the Sanjeev list?
Yes, sir.
Yeah. Okay. So, I'll ask Dr. Krishnan, how would one approach the potential suspicion of anemia over here in this particular case? I think you alluded to many of the things, but if you just like to, in this particular patient, how would you want to approach this patient? What would be your advice to the patient, and what are the relevant investigations we want to do over here to achieve, to come across a diagnosis? I mean, to at least come close to a diagnosis. What like?
In this case, first of all, we review the peripheral blood smear again and with reticulocyte count. If there is a reticulocytosis, then we can suspect the anemia in this patient may be due to the hemolytic anemia. And if there is a reticulocytosis increased LDH level, and we should do the direct wound test and indirect wound test. If there is a trend to be positive, then autoimmune hemolytic anemia is a definite diagnosis in this patient. If BCT comes to be negative, then another cause of anemia should be found out, and if anemia can be attributed to the underlying condition like plasma cell dyscrasia, and for that we should do a bone marrow expression and biopsy. Along with that, we should go for the ILC or the flow cytometry and serum protein electrophoresis, immunoelectrophoresis, and along with that the free light chain assay and other relevant tests to confirm the diagnosis of the plasma cell dyscrasia.
So, as we received 2 transfusions when the patient came to us, and her hemoglobin was 7.5 when she came, but we did the other test, and there was an increase in the lambda light chains over here, and the immunoglobulin profile, which we just sent over there because of the because in the main total protein there was in a previous value, this was a subsequent test, there was hyperproteinemia, and the protein was about 10.6. That's what triggered us to do the panel of immunofixation, electrophoresis over here, and the free light chain assay. And there was a slight increase in the lambda, and the total protein was, and the IgM was distinctly elevated over here. So it was a little bit of a surprise, because we were thinking that this is an autoimmune hemolytic anemia in the background of a CLPD, and that's how we worked on it. But for doing electrophoresis, and then we were surprised when the IgM came back. So it was not intended, but it came back. So, and as you rightly said, the reti count was about 6 for this patient. So there was some, and if you notice that the bilirubin was around 3.3, which was mainly indirect. Yeah. So, so we did do a peripheral blood. We simultaneously processed for a peripheral blood flow cytometry, which clearly demonstrated a CLPD picture, lambda restriction, and also we reviewed the outside bone marrow which was done at our center. We didn't repeat a bone marrow, and that bone marrow, actually, when you look carefully, there are pockets at the bone marrow, because there are different patterns of distribution in a lymphoplastic lymphoma in the bone marrow, ranging from very small pockets of nodular involvement. These are some sort of interstitial involvement, which Dr. Manchanda will talk to subsequently. So, and of course, that was a serial necrophoresis pattern, which on immunofixation showed an IgM. So, this patient, from the perspective of the diagnosis, predominantly presenting with a hemolytic-like picture, anemia, and the close differential diagnosis over here was a marginal zone lymphoma. That is something also that has to be kept in mind. But you don't get IgM in a nodal marginal zone lymphoma. So that is one thing. And of course, if you really want to be discerning over here, you might go ahead and do the MYD88 mutation, because in a nodular marginal zone it will be negative, whereas in the Waldenstrom it will be positive. Most of the time, not always. So, so that is what for the first case is focusing on anemia. So I come to a second patient, is a 66-year-old gentleman. This is also a little bit of not a straightforward case. This all is real life actually, this, which I had a difficulty in identifying. And he was a 66-year-old, relatively unwell for more than 1.5 years for this patient, with fatigue, mild weight loss, and low energy levels. And he had a history of intermittent epistaxis and gum bleeding. And during a dental evaluation, he was found to have a low hemoglobin of 6.4. And he went, at this point, he was referred to a hematologist, underwent a bone marrow assessment, which showed 20% plasmacytosis. That was what was described. And also underwent a serum electrophoresis, which showed a dense monoclonal band of 3.64. Immunofixation revealed again an IgM heavy chain. And kappa light chain was grossly elevated at 3,201. So beta 2 microglobin was elevated. There was no abnormality of the renal function, and he had already subjected to a PET scan, which we don't generally recommend, but it was already done, so I've just put it up over here. And there were a few lytic lesions involving the ribs and manubrium. So here we have an IgM, we have a high levels of free light chains over here, a few lytic lesions, and reported plasmacytosis. Pankaj, how would you interpret this particular thing? I mean, in the sense, it is not a clear-cut picture, but because would you encounter, one thing is, would you encounter such a high free light chain assay if you're considering IgM or a Waldenstrom?
Yeah, obviously this is a little tricky case, and you already said this is a challenging case, because once you find the lytic areas, then it tilt the balance towards some.
It's not too common to have lytic lesions.
Yes.
In Waldenstrom.
So generally, if there are lytic areas, then you consider, it's more like a myeloma, or entity which is called IgM myeloma. So sometimes it is very difficult to differentiate IgM multiple myeloma from Waldenstrom microglobulinemia. So here, so this picture can fit into both the situations that you require both tests to clearly delineate.
But we did never encounter this kind of a high free light change, do we, in Waldenstrom?
So that's what I said. It can happen in Waldenstrom also, it can happen in myeloma also. So the test which can differentiate is one is the 88 test and the other is the, if you get as translocations which are more common in myeloma, let's say this patient gets 11, 14 translocations, then this patient would be labeled as IgM myeloma, not Waldenstrom. Whereas if you get MYD88 mutation, then you would say this is behaving like a Waldenstrom with the lytic areas which are atypical presentation of a Waldenstrom macroglobulinemia, including, as we said, the light chains which are elevated in this patient.
Yeah, and Dr. Sanjeev,
I will not consider it as a IgM myeloma at all. That's a case of Waldenstrom only, and I will like to do cytogenetics and FISH panel for myeloma for this patient. Usually Waldenstrom patient will have 6q abnormalities in cytogenetics, and myeloma patients have high risk translocation, deletions or mutations. So that I will like to rule out first. And IgM myeloma is a very rare diagnosis, only few case reports in literature. So rare things are rare, common things are common.
So we went through we reviewed his bone marrows actually over here, and this was a bone marrow picture. There was a lot of abnormality of lymphoplasmacytic kind of cells over here, which I will reveal on the on the 100x over here, which showed lymphoplasmacytic cells. But also my colleague in pathology said there were other myeloma plasma cells also with it. It's a mixture of lymphoplasmacytic cells and myeloma cells over here. It was, and the important thing was CD79A was positive over here, and CD138 was also positive. MUM1 was negative, and CD56 was negative over here. So it was not a very, very clear picture of that of a. Thank you, Dr. Sanjeev. Yeah, thank you. So that is the kind of picture. It is not very clear cut over here in this patient. So again, I mean, because this is a discussion on the side effect. I mean, the symptoms and signs of lymphoma. I have not gone into the treatment protocol, but in a nutshell, I will say that this patient had splenomegaly. We thought it was lymphoplasmacytic lymphoma. We thought it was more like a Waldenstrom, despite the and we treated him with bendamustine, rituximab. What happened was he responded beautifully. His splenomegaly completely resolved, and but when we did his marrow at the end of 6 cycles of BR, all the lymphoplasmacytic cells had disappeared, but the myeloma cells were still very much present over there, and his free light chains had not completely normalized, and he still had a monoclonal band, and it was IgM, and he was symptomatic, and then I kept him on follow-up, but the patient went on to have progression again, and this time again when we did the marrow, it was not the lymphoplasmacytic cells, it was an increase in the plasma cells, and it was again the IgM levels had gone up, and so we switched gears over here and started treating him like an IgM myeloma. I could do the cytogenetics. It would have been nice to do a 11-14 over there, but I couldn't get that report. So we treated him for myeloma, and that was 3 years ago, and he's still following up with some sort, and he is on maintenance therapy. Now he's off maintenance and he's maintaining his levels. So it was not a clear-cut picture over here at all. So, but the working diagnosis was he had a mixture of both, but without a doubt. But we have documentation of clearance of lymphoplasmacytic cells with chemoimmunotherapy. So, the case 3 is a 75-year-old patient, a gentleman who presented with some hyperpigmented lesions over his forehead, and the lesions were there for about 2 years. He had undergone a punch biopsy which showed scattered dense lymphocytic nodules and follicles in the dermis composed of large centroblast-like and small centrocyte-like cells. And these follicular B cells express CD10, BCL6, and very equivocal for BCL2. and lacked MUM1, and the plasma cells were appreciated at the center of a few follicles. Then subsequently, a flow cytometry was identified a population of B cells with phenotype of CD19 positivity, CD20 positive, 79A, and FMC7 positive. Largely, no IGH1 BCL2 translocation detected on the skin biopsy. So, a bone marrow biopsy done in December 20 showed diffuse infiltration by small lymphocytes and mature appearing plasma cells over here. CD20 staining identified B cells, and CD138 showed lambda restricted plasma cells. And he was treated with the bendamustine rituximab protocol. So, how many times do we encounter lymphoplasma cells presenting the cutaneous involvement? At least in my clinical practice in India, we haven't had so much, but Dr. Markovich.
Yes, again, it is a rare, you are all showing the rare patients of,
No, because I just want to show you the straightforward ones we can actually pick up.
So again, the skin manifestations in patients with plasma cell dysplasia, especially the Waldenstrom, are rare. And here the other interesting thing is that, on the biopsy you show CD10 positive, whereas on the flow cytometry CD10 is negative.
Yeah, so that's possible.
Yeah, so that is the other one. And yes, otherwise, I would only say that this is a rare kind of a thing, and probably you have to get to the DR protocol. I am interested in knowing what happened to the skin lesions in this patient.
Yeah, they disappeared, and the patient was asymptomatic for almost 4 years after this. And I will tell you subsequently what happened. Any comments on this?
I think it's more.
First of all, cutaneous manifestations.
Cutaneous manifestations in this patient may be due to the cryoglobulinemia.
So, are we better off by asking biopsies and all these lesions and then understanding the issues over here? Question as a clinician screen across so that we can identify earlier. Because this patient did not have anything in the blood, which is really difficult.
The presentation is more like a lymphomatous presentation.
Yeah.
Rather than
I agree, yeah. So, the disease remained quiescent for almost 4 years. He was followed up for 4 years, but at this point he developed a right brachial plexus, upper extremity weakness with swelling and pain, and there was a small lesion mass sitting over there, and the cytology for FNAC showed clonal intermediate large lymphoid cells from there. And the molecular testing of the soft tissue sample detected MYD88 mutation, and he developed, during this time, he developed progressive intermittent confusion and disorientation, following which thinking in terms of a meningitis, we did a CSF, and that showed about 420 nucleated cells. The CSF cytology was highly cellular, consistent with non-Hodgkin's lymphoma. So, then we'll just come to the treatment a little later, but how often do you see neurological manifestations in patients with Waldenstrom?
Actually, I have never seen the Waldenstrom's microglobulin CNS presentation live. I only seen the patient with the peripheral neuropathy.
So,
Never encountered.
on the pathogenesis of this. Do you see it as a primary presentation, Dr. Markovich? Do you really see it as a primary? Yeah, you can just start.
When I reviewed this series of cases, so I have found one patient who actually has moderate Waldenstrom, who was on observation later developing.
Okay. Usually you don't encounter it in the first time around. Usually the patients will be treated subsequently. And any thoughts on the pathogenesis?
So in these patients, we believe that the lymphocytes actually go to the brain and they cause these symptoms. And the good thing is now we have tyrosine kinase inhibitor, protein tyrosine kinase inhibitor drugs, which crosses the blood-brain barrier, and the prognosis of these patients have improved considerably. So even in this patient we have mentioned that patient was put on ibrutinib, and there are gradual.
So the important thing is that when you have CNS involvement, and it is directly due to infiltration of the lymphocytes into the CNS, especially into the tissue, causing this confusion. Something like a primary central nervous system lymphoma like manifestation over here. And interestingly, the patient did not respond to any of the chemotherapy drugs. And we know now that this particular condition is best treated with a tyrosine kinase inhibitor over here. And that's what happened. So we provisionally said that this could have been a big Niels syndrome when it is seen as manifestation of Waldenstrom, that is what the patient had. So I just, in order to go through, I don't have any cases specifically which I have seen, so I've just put it up. Hyperviscosity syndrome. So how do we manage hyperviscosity? Where do you suspect hyperviscosity syndrome in a Waldenstrom? And that will trigger us to think about Waldenstrom. What are the features of?
When patient presented with the symptoms of hyperviscosity, that he had a blurred vision, bleeding manifestation like epistaxis, GI bleed, gum bleeding, and then we should suspect the hyperviscosity syndrome in these patients. And hyperviscosity syndrome is treated as a medical emergency. We should do urgent plasmapheresis to bring down the IgM level at least below the 3 gram per deciliter. And at that time, after bringing down the IgM level, we should concurrently initiate the chemotherapy-based regimens, that is exclude the initially exclude rituximab, but after the control of the IgM level, we add on the rituximab-based regimen in that.
Yeah. So is there any sequencing that you would look at, Pankaj Jaswant, when you encounter somebody with a hyperviscosity syndrome? Is there any sequencing that you would like to do?
Yeah, the first thing is to do the plasmapheresis of these patients, take out the IgM, as early as possible. So generally 2 to 3 sessions of plasmapheresis will at least take care of the circulating IgM, and and then you can consider giving the chemotherapy to these patients to further stop the production of IgM. So immediate relief of symptoms is must whenever some patient have come with the hyperviscosity features, and plasmapheresis is a good option for them.
So would you like to take out your ophthalmoscope over here now? Yes. So
Yes, so retinal examination is a very important thing to do in diagnosing hyperviscosity. You will see a finding called sausage-like appearance.
So that's primarily because of the coating of the IgM along the vessels, and that's, I don't know, it's not very clear over here. You can see the IgM actually inside the blood vessels under the thing, and that is what Dr. Seth mentioned, that it is a sausage-like appearance, and you can have hemorrhages also in terms of. So the same kind of a thing that happens in the you tend to get epistaxis because of engorgement, because of the IgM in the small capillaries, which actually bursts the small capillaries in the nasal, which causes the epistaxis. And epistaxis is not a manifestation of coagulopathy, but is a manifestation of the hyperviscosity rather over here. That's what one needs to understand. And also bleeding per rectum is also one of the features in hyperviscosity, because of the thin vessels they also burst, and the patient tends to get using hand. So we already discussed about the skin involvement over here. Some of the skin, we don't see too much of skin involvement, but we see GI involvement. Many of our patients present with rectal bleed and fresh blood in stools, because some of the fair individuals, we do, these I have just taken pictures from, because we don't see it in the Indian population. Really cannot see this any time. But you can get erythema of your palm, that basically because of cryoglobulinemia, hyperviscosity, because of the temperature variation, especially if you're in a cold climate, you will get cryoglobulinemia, because of which you will have this kind of a picture for patients. And so one has to think about this aspect when we treat patients. And of course, there's endoscopy, colonoscopy reveals very thin walled vessels, and this is the classical picture that you see. Sometimes you can even see small nodules present in the colon, which is because of the Waldenstrom, the pathogenesis related to the Waldenstrom's macroglobulinemia and the immunoglobulins. So, is it over? I finished. Okay. Yeah. So those are some of the things that we see. There are the myriad manifestations of Waldenstrom, but more important for us to keep in mind that these possibilities do exist. Listen to the patient, because many a time the patients will tell you the symptoms, and we have to correlate between the two to actually trigger an investigation for the patient, which is relevant for us to pick up. Diagnosis is easy, but for us to listen to the patient and correlate one another very carefully is the key to understanding Waldenstrom's and identifying Waldenstrom's. So if there are any questions from the audience, we would be happy to take. Yes. Thank you.
Looking at all the case presentations and Professor Uday sir's lecture and everything, now as I recollect my memories about my mother's disease progression and the experience we had with her, in her case, she always complained of fatigue. She had some kind of joint pain for which we were taking physiotherapies. And also in 2004, if I remember correctly, it was the eye manifestation, which was a vasculitis, and there was a hemorrhage in one right eye. And then it all started with the peripheral neuropathy, for which we did everything to figure out what it was, and we never could figure it out until unless we went for this bone marrow biopsy, which showed this IgM monoclonal glands in this. So it's such a masquerading syndrome that being in a doctor family, surrounded by all the eminent doctors and consulting everybody at that stage, in those 20 years back, we couldn't even figure out the disease, what she was suffering through, and all the pain she was going through. This has been a biggest challenge of our life. But yes, it was also very difficult to treat all of that. We started with the rituximab, but we got the serious manifestations of the hemorrhage and the stroke, and there were very many cardiac manifestations with the arrhythmias and everything, which I think she was one of the most challenging, difficult to diagnose and to treat the patient. She suffered a lot, and I'm so honored today that we could get so many doctors today in this place to give their valuable opinion and their experiences, share with us about all the challenges they face diagnosing such cases. And I'm really very grateful to all of you to come over here and to start with this chapter in India. And I think we should really open our eyes, because our eyes don't see what we don't know, what our mind doesn't know. So it's really a great opportunity for all of us to have you all over here to share your experiences and to make us all aware of such cases. And sir, you have already shared so many rare presentations of Waldenstrom in your slides with the cases you have gone through. But yes, right now we have so many diagnostic tools available, the genetic testing and all that available. But to keep that in mind also is a challenge which is being faced by the physicians, who are the first-hand approach to the patients, who are going for their primary cause of concern, the symptoms, because until and unless those primary care physicians are upgraded, even like sir shared that, opthal manifestation, neuro manifestation, rheumatoid manifestations, hemat manifestation, onco manifestations, every every organ is being affected by such a disease. So until and unless each and every one is aware of such a kind of disease which is being there, nobody will look for it. So thank you a lot, sir. Thanks. It just brought me so many memories, and I just wanted to share it on behalf of all of us. Thank you so much.
I know what you said, but you must understand that not all manifestations happen in the same patient, and perhaps your mother had this issue because of long-standing. Perhaps it was rare to have amyloid in Waldenström. It's not a common feature. You can mimic. You can have rheumatoid arthritis as a mimic over here, because even if you do a RA testing, you might get a positive thing but it's a false positive actually. And neuropathy can be a only manifestation of Waldenström because of the antimyelin, because a direct infiltration by the lymphocytes into the myelin sheath is not an autoimmune kind of a thing. So yeah, it's always challenging. Nothing is straightforward, but the important thing is to keep an open mind. And I always tell my students when I say, listen to the patient, take time to listen to the patient, and then you will, many a time you will have something to go by just listening to them. And as I said, I was talking to Pankaj about the ruler formation. That's a simple thing. Just seeing a ruler formation can trigger a whole lot of investigations for the particular patient, without a doubt. And it's not something that, but unfortunately, we don't see those reports. People don't pay attention to that. And that's the kind of things that we see. So, yeah, so it's all attention, a little bit of attention to detail. And it's all clinical medicine. All other things comes later on, actually. You were talking about the molecular. It is not so important to do the molecular testing in this thing. When we want to use some specific kind of a treatment, then we may use some molecular testing. For example, to be more discerning about the kind of BTK inhibitor that you will use, or what is going to be the effect of your chemotherapy, whether you want to use a BTK inhibitor earlier than chemotherapy. All those have come up in chronic lymphatic leukemia. Now I'm sure after 2 years when I'm speaking about it, probably we won't have chemotherapy in the armamentarium at all. So everything is evolving. And yeah, it's unfortunate sometimes, and sometimes when patients come to you in your clinic, you just see as to why you were not picked up, why this was not picked up earlier, but perhaps it was not as evident at that time. But you have to pay attention to detail, that's important.